Okay.
So my case scenario is 26 years old female with BMI of 38 kilogram per meter square planned for liposuction abdominoplasty.
Okay.
The concerns in this case scenario are difficult intravenous access, difficult airway, proper positioning of the patient during intubation and extubation, titrated use of narcotics, avoid rapid rehydration, and administration of anesthetic agents based on the lean body weight and total body weight. And other concerns are pulmonary edema, volume overload, local anesthesia, systemic toxicity due to tumescent anesthesia for liposuction. Since it is a elective planned cosmetic surgery, I would like to evaluate and optimize the patient prior to the surgery. From history, I will ask for history of any habitual snoring, nocturnal choking, frequent disturbances of breathing during sleeping, and excessive daytime sleepiness in order to rule out obstructive sleep apnea. And in past history, I will ask for any diabetes mellitus, dyslipidemia, and on any medications will ask. Sir. In case of any, sorry, uh, in airway examination, I will look for Malambati grade, thyromental distance, mouth opening, neck movements, and I will look for it. Investigation, I will start from routine investigation in hemogram and biochemistry profile and electrocardiogram, echocardiogram, chest X-ray, USG, ultrasound, neck, pulmonary function test, and ABG and sleep studies to grade the severity of obstructive sleep apnea if it is a positive history. And my plan for this surgery is combined general anesthesia with epidural anesthesia with catheter in situ for both intraoperative and postoperative analgesia. In case of anticipated difficulty airway, I will counsel the patient for awake fiber optic intubation. Under standard anesthesia monitoring conditions, I will do awake fiber optic intubation. Sir.
Awake fiber optic. Which one is confusing both? Okay, go ahead. Now, supposing the examiner asks you, this 26, what is the age? 26 years old female, the BMI of 38, comes for this procedure and you are the anesthetist. Tell me step by step how you will anesthetize this patient. If that is the question, what are you going to say? Practical
evaluate
of
first,
this
sir.
case.
Evaluate the patient first, sir.
Okay, how are you going to evaluate the patient?
By doing investigations such as routine hemogram and biochemical profile.
Clinically, first you have to examination. Always starts with clinical examination. Okay.
Yes,
so, what are the clinical concerns in this case? You have already mentioned some points there: airway, IV access. So,
yes, sir.
how do you know whether it is going to be a difficult airway or easy airway?
So by airway examination, mouth opening, sir.
Okay.
Malambati grade.
Mouth opening, how much you want mouth opening? What is the normal? Tell the normal value for each and every.
3 finger breadth, sir. 6 centimeter or 6 centimeter.
Okay, right. Inches are different.
Yes, sir.
Then
Malambati grade, sir.
Malambati grade. Supposing it is Malambati grade 2 and mouth opening is more than 6 centimeters. Neck movements are normal. Neck mobility is good. Thyromental distance is more than 6 centimeters. Is it a difficult airway or an easy airway?
Sir, no, so easy airway.
Easy airway. Supposing the neck circumference is more than 40 centimeters. Is it a difficult airway or an easy airway? What is a normal step by which you can decide whether it is going to be difficult or not?
Sorry, sir, unable to hear.
How do you define a difficult airway? This is how the exam question will be there. So how to define a difficult airway?
Inability of the anesthetist to maintain saturation of more than 90% by bag and mask ventilation.
So what was the earlier definition? It is somewhat recent definition, but the earlier definition of difficult airway. Conventionally trained anesthetist unable to do bag and mask ventilation or intubate the patient within 3 attempts is supposed to be a difficult airway. It is a conventionally trained anesthetist. Why that conventional training was the word included in the definition of difficult airway? And now why they have changed it to desaturation? Any other exam going who can answer this? Unita or Sai Dixit? Unita, are you there?
Yes, sir.
So what is why they have changed it slightly from the older definition of a conventionally trained anesthetist? What is the conventional training?
Sir, they are
Trained
trained to intubate the patient.
Trained to intubate by intravenous induction, paralysis with a neuromuscular blocking agent, ventilate the patient with bag and mask to maintain the oxygenation, then do a laryngoscopy and intubate the patient. This is the conventional training. In what way this training has improved now or changed?
So because of simulation.
Earlier we had only one type of laryngoscope. What is that? Macintosh laryngoscope. We were all trained only with that about in our generations. But now your generation, you are using straight away video laryngoscope. So many other gadgets like LMA has come. So there are other methods of maintaining the saturation. That is why they have switched over from the conventional trained anesthetist to inability to maintain a saturation. Even with all these gadgets and other equipments that we have nowadays, if you are not able to maintain a saturation of more than 90%, it is called as a difficult airway. Okay? You understand why it is there? This difference is there in the definition now. Muthumani, are you able to appreciate that?
Yes, sir.
Okay, right. So you have to make sure that the airway is processed properly. Now, this in relevance to that, another question they may ask you is what are all the respiratory changes that happen in obesity? First of all, this 38 BMI, under what class of obesity it comes? That is a very important thing that you have to mention in the examination. How do you classify obesity?
This is grade 2 obesity, sir, or morbid obesity.
Class 2. Class 2. 25 to 30 is overweight. 30 to 35 is class 1. Class 35 to 40 is class 2. 40 and above is called class 3. Earlier it was called morbid, then super morbid. All that has now been removed by WHO. So it comes under class 1, class 2 and class 3 only. So this 38 it comes under class 3. So class 3 invariably you may have anticipated difficult airway. So if that is present, what is your plan? Can you do liposuction under spinal anesthesia? Abdominoplasty and liposuction under spinal anesthesia?
If the duration of surgery is more than 3 hours or 4 hours.
It depends on the surgeon's speed, isn't it?
Yes, sir.
So if the surgeon is fast enough, you can even do it under spinal. There's no harm because it is only a superficial procedure. They are not going to go inside the abdomen and do anything. It is all just the skin and subcutaneous level only. Cutting off the excess fat and skin and tighten it and produce a smart looking abdomen. Okay, so this can be managed if the surgeon is quite fast enough, but majority of the time we may require general anesthesia if the duration is long, as you rightly said. So in giving GA, you have to make sure that you have a secure airway. So what are all the respiratory system changes that can happen if you have the obesity, in that class 3 obesity?
Sir, obstructive sleep apnea, sir.
Obstructive sleep apnea is a pathological condition of the upper airway. My question is, what are the changes in the respiratory system itself? Lower down in the
Restrictive lung pattern will be there.
restrictive
Reduced lung volumes,
which are all the
reduced
volumes
lung
and
volume and lung
capacities which are
compliances.
reduced? Which are all the
Sir,
volumes
forced
and
vital
capacities?
capacity, functional residual volume, total lung volume, closing
Functional
volume.
residual capacity, not functional residual volume is not there. Functional residual capacity, FRC, PLC, ERV, respiratory reserve volume, FRC and PLC, these are the three things which are reduced in obesity. Why there is a reduction? What is the pathophysiology behind this reduction in obesity, that to class 3 obesity?
Due to decreased lung wall and chest wall compliance. Sir.
Why? Deposition
Excessive
of
fat deposition.
Fat deposition, and it happens not only in between the ribs, in chest wall, it also happens in the diaphragm. So every important component of the respiratory function is affected by this fat deposition. Okay, so that is why it is becoming acting like a restrictive airway disease, not an obstructive but a restrictive airway disease. Supposing this patient is tachypneic all the time, is there any way to find out whether they will have post-operative respiratory failure or not? Any test which can reveal that an obese patient with a severe restrictive type of respiratory function and go in for a respiratory failure post-operatively? Is there any pre-operative evaluation method for that?
The pulmonary function test.
Pulmonary function test. What is ventilatory failure? When will we call a patient as ventilatory failure or respiratory failure?
CO2 retention.
CO2 retention,
CO2
excellent.
retention.
That is
By
very, very
saying
important. So
bicarbonate
you do an ABG and find if their how CO2, PaCO2 is higher than 50 millimeters of mercury, that patient is likely to go in for post-op respiratory failure. Okay. So in all obese patients who are tachypneic, who have limited exercise tolerance, you should do a arterial blood gas analysis to find out the PaCO2, to find out whether they are already in respiratory failure, and if they are in respiratory failure, which may not be clinically very evident, you have to be prepared for a elective post-op ventilation to manage them. Okay, so very, very important point that you have to remember. Right. Another question they may ask you is, how do you know what is the pathophysiology in this obesity, in this lady? What are the causes of obesity? How does obesity occur?
Primarily BMR, sir, energy expenditure versus energy intake of imbalance. Sir.
Okay.
Then cellular disturbances, sir. Decrease in insulin secretion or insulin resistance. Genetic factors such as mutations in leptin, adiponectin.
Very good. Okay, very good. Any in the examination, is there any way to quickly answer this in one line? Vinita? Etiology or it is multifactorial. One sentence answer for this is, it is multifactorial, environmental, hormonal or genetic causes. If you say that, they will not ask you any more questions. Okay. So instead of trying to explain each and every answer, you say this one single answer. What is the etiology or pathophysiology of obesity? It is multifactorial. It may be due to environmental, which means patient may be a binge eater. Every time he eats a very heavy breakfast, immediately some snacks, then lunch, then afternoon snacks, again night dinner, then late night eating. So that is all environmental factor. Okay? Then hormonal, the imbalance between the satiety and the hunger producing hormone, ghrelin and the leptin. Okay? Then third is the mutations in the human genes can be modified. So how do you know whether it is a genetic cause?
Family
You
history.
find out family, whether mother is
Family.
also fat, whether sister is also fat, whether brother and father are fat. If you ask that question, you can find out whether it is genetic. Okay, so like that, supposing you get a live patient, you will have to ask all these questions to find out the etiology of obesity. Whether it is the patient's eating habit, or whether it's the patient's sedentary life, or whether it runs in the family by asking the about the weight of the family members and all the whether any treatment, conservative management was tried. So patient will simply say, I had a very prominent abdomen and so I saw a TV ad and then I thought I will get fat removed and become more slimmer and look better. So especially 26 years, if they is married, they want to have a better appearance, they will definitely come for this procedure only by word of mouth or by seeing the ads and other things. So that will be the only thing. So what comorbidities usually exist in these patients? They have this class 3 obesities.
Dyslipidemia, diabetes mellitus.
What is metabolic syndrome? Especially when somebody comes for an abdominal correction with obesity more located in the abdomen. Are you worried about metabolic syndrome?
Yes, sir.
What is metabolic syndrome and what are the components of metabolic syndrome?
So it comes. So the components are fasting blood sugar greater than or equal to 110 milligram per deciliter and systemic hypertension of B of greater than or equal to 130 of 85 millimeter of mercury, hypertriglyceridemia of more than or equal to 150 milligram per deciliter, decrease in high density lipoproteins of less than 40 milligram per deciliter in men and less than 50 milligram per deciliter in woman, and waist circumference of greater than 1 or 2 centimeter in male and less than 80 greater than 80 centimeter in female. Out of 5 components, any 3 is positive for metabolic syndromes.
Okay, very good, excellent. What is the other name for this metabolic syndrome?
Syndrome X, sir.
Syndrome X, excellent. What is the danger of this? You are worried about
So
metabolic syndrome?
To increase the incidence of coronary artery disease, stroke, and thromboembolism, sir.
Sudden death. Sudden death is one of the important complications of metabolic syndrome. Patient may apparently look normal. So if they have any of the 3 of these 5 components, post-op sudden death or intra sudden death is very common in the metabolic syndrome patient. Okay? So we are worried about that. Right. So what are the 3 anesthetics optimizations you would like to do if it is a difficult airway case as suggested by that, and if the patient also gives history positive of obstructive sleep apnea? This lady is posted for abdominal and liposuction. If she gives history suggestive of obstructive sleep apnea, how will you find out whether she has OSA? Because patient may not immediately say I have OSA and all those history may not be there. If they give you a live patient, they will just say I have been growing fat, my abdomen is becoming fatter, I have come for a corrective procedure. So you have to find out whether they have OSA or not. So what questions you will ask them to find out the presence of OSA?
So stop bank questionnaire, sir.
Excellent. Very good.
History
So
of,
what
history
are
of
the
snoring.
components of stop bank? Stop
History
bank
of snoring, sir.
is only the question. Bank is the
Yes.
examination. Okay.
Yes.
Stop bank questionnaire. The first four letters STOP are about the history or the complaints or the questioning of the patient. Bang is for the examination point. So what are all the components of stop? Snoring,
Snoring, morning, daytime sleepiness,
tiredness.
any.
T for tiredness, early morning tiredness. Even after sleeping and getting up, they feel very tired. O is for obstruction. P is for
History
pressure.
of any obstructs.
Have history of hypertension also. Bang is for BMI. A for age, N for neck circumference,
N for
G
neck
for
circumference
gender.
and G for gender, sir.
Okay. So by that you can ask whether they have this problem. If they have problem and if they are not aware of that, what should you do?
I will do polysomnography sleep study, sir, to
Very
grade the
good.
severity of obstructive sleep apnea.
Excellent. What is the important component in that polysomnography? It will tell you about the severity of this condition.
Sir,
For
oxygen
obstructive
saturation.
sleep apnea, you measure so many parameters. But out of
Yes,
all
sir.
the parameters, which is the most important parameter by which you will assess the severity of this particular condition?
AHI.
AHI index, apnea hypopnea index.
Apnea
Okay?
index.
That is the one you should remember. You have to say about apnea hypopnea index. Okay, and that only decides the severity. And supposing it belongs to a very severe grade of OSA, will you take up the patient straight away for surgery or will you have to optimize the patient?
Will optimize first, sir.
Yes.
Okay. So what are the methods of optimization?
So we can go for lifestyle modification, CPAP, BiPAP,
Yes,
sir. If it
very good.
fails, we can plan for surgery such as uvulopalatopharyngoplasty, sir.
On that much extent, you can wait. After all, this is cosmetic procedure. So by lifestyle modification and trying to reduce the weight itself can improve both this abdomen problem as well as the OSA problem. Okay. So in spite of that, if the weight is not coming down, then you have to go for CPAP or BiPAP. And if they improve with CPAP and BiPAP, what instructions you will have to give in the pre-anesthetic counseling time?
So advise the patient to bring the same CPAP machine which they are using in homes, sir.
Very
Since
good.
the
Very
patient
good.
adapt to it, they can use it in a hospital without any
Very good. So that
uneasiness.
is a very important instruction that should be given to the patient. Okay, right. What are all the challenges in this patient's management intraoperative? So pre-op, you control all the comorbidities and try to optimize them as much as possible. If they have hypertension, control that. If they have diabetes, control that. If they have OSA, give them CPAP. So all the optimizations have to be done, and then you plan for procedure. Intraoperatively, what are the challenges for you?
So there will be difficult intravenous access, sir.
First positioning, intravenous
It's
access
a it's
there. So depending upon the patient's weight, this 38 is class 3. So you must see whether the normal table will be able to accommodate your patient. Okay.
no,
So
sir.
that's another important thing that you have to remember. Optimize to prepare the OT adequately. Then what is the position you want to adopt for this surgery?
So for surgery, sir.
What is the position you want the patient to be in for this liposuction and abdominoplasty? It's simple supine position only, isn't it?
Yes, sir.
But
Yes,
you
sir.
want to do any modification to the supine position for your convenience.
Reverse
So
Trendelenburg.
during intubation and during extubation,
You
I
are
will
not
prefer reverse
started
Trendelenburg
intubation
push.
itself, you are working about extubation. I'm asking about starting the surgery.
Yes, sir. I will do reverse Trendelenburg position, sir.
Head
For
up
head and
tilt.
elevation.
Better always say head up. Reverse control bus may not be the ideal wording to use in the examination. It is better to say 25 to 30-degree head up tilt with ramp position, R-A-M-P, ramp position. Especially class 3 patients, even if there is a manageable airway, better to have what is called RAMP or ramp position. Right? How do you adopt the ramp position?
Sir,
How do you put the patient in ramp position? RAMP, ramp position.
Pillows
by placing the
Where
pillow
does
under
the
the
pillow
patient's
go?
shoulders.
under
See,
the
for
shoulders.
normal
We can roll the
intubation,
sheets
yeah,
under the
for
In
shoulder.
order
normal
to make
intubation, we don't require any support under the shoulders. Okay. Whereas for a obese patient, the support should start from the upper part of the shoulder to the entire neck and the opposite. Okay. So that what is the idea of this ramp position? What are the things that you want to
uh,
align?
to align the
External
external
auditory
auditory
meatus
meatus and
and
sternum in the same.
External auditory meatus to the suprasternal notch. That should come in the same line. Okay, that is the idea. So if you do that, then it will be easy to introduce your laryngoscope and visualize the glottis and intubate the patient. Okay, that is the answer that you have to give. And what is the importance of pre-oxygenation? Why do you want to pre-oxygenate well in this patient? You have already said some
These
warnings.
patients they will be more prone for rapid desaturation.
Rapid desaturation
Rapid
due to
desaturation, and there will be
increased
shorter safe
capillary.
apnea periods.
Oh, so you have to manage. So supposing this patient requires instead of abdominoplasty and liposuction, she has come for a bariatric surgery for a weight reduction. How is it done? This is how the case scenario may suddenly jump in the examination. Instead of asking about abdominoplasty, liposuction, they can ask you suddenly about bariatric procedure. Because this is a class 3 obesity, patient wants weight reduction of the entire body instead of only the abdomen. And she has come for a bariatric surgery. What are all the bariatric procedures that are done to make the patient lose weight?
So gastric sleeve resection, bypass surgeries.
Okay. So surgeries which prevent absorption of too much of food and make the patient eat less. That is the basis of bariatric procedure. Okay. So reduce the capacity of the stomach so that patient feels satisfied even with a smaller quantity of food intake, thereby reduce the intake of calories, which will result in reduction in fat deposition and patient loses weight. Okay, that is the basic principle of bariatric surgery. But what are all the risks involved or the challenges in the bariatric procedure? Is there any scoring system to find out the mortality or morbidity in bariatric surgery? No.
OSMRS,
Ah,
obesity surgery.
BS,
Not
BS, bariatric surgery, morbidity risk scoring, MRS, BS, MRS. Okay, that scoring is there to find out what is the chances of morbidity or mortality in obesity patient. Okay, so what is the ideal GA technique for any obese patient? What are all the agents that you can safely use to make them recover faster?
Rapid sequence
Operative.
induction with cricket pressure.
this
Induction agents which you used are propofol and scolding.
Okay. Maintenance,
desflurane,
just fluorine with analgesic, especially
Repeatedly.
if they have OSA.
remifentanil,
Epidural
Multimodal analgesia or epidural analgesia.
patients, as you just simply say it's so easy to do an epidural in a class 3 obese patient. Many times you won't even feel the sinus process.
Yes,
by
sir.
calendar. So the ideal technique described nowadays is a combination of desflurane, ketamine, and dexmedetomidine. Okay? So infusion of low dose ketamine, infusion of dexmedetomidine with inhalation with desflurane has been found to be the most ideal technique for obese patients, which gives excellent analgesia and a rapid recovery at the end of the day. Okay? So this is the thing that you have to remember. So already we have gone past the time schedule I told you. Anyway, I'll just share another screen for you.